stop there and...
We're now to Dr. Marks. Thank you very much for joining us, Dr. Marks, and providing the two-front war from NIH and CDC.
Thank you, Mr. Chairman. I'm especially pleased to be here today to talk with you about CDC's National Breast and Cervical Cancer Early Detection Program. It's in its 11th year of providing free mammograms and pap smears to low-income American women. This program has saved lives and raised the consciousness of Americans everywhere about the importance of screening. And I especially want to put our program in context with what you've just heard from Rick. When the research is done, it needs to get out and get out quickly to the American public, to those in great need. As he described, we know how to save many of the deaths that now occur from breast cancer. Mammography is currently the single most effective method for diagnosing breast cancer early. And the longer that breast cancer remains undetected and untreated, the greater the likelihood it'll spread and eventually result in death. We fund programs in all 50 states, the 6 U.S. territories, and in 12 Native American and Alaska Native tribal organizations. In addition, we provide health education to the public, to health professionals, and pay for a variety of the medical procedures that lead to confirming diagnosis. Through September of 2000, we have provided over 3 million screenings. About 1.4 million of those are mammograms. And about 9,500 women have been diagnosed with breast cancer through the program and helped to find prompt treatment. If this program did not exist, these women would still have cancer, but they would not be able to afford mammography, and the diagnosis would have been delayed to 1, 2, or even 3 years until they could feel the cancer themselves. They would not have had someone working on their behalf to find treatment for them, and thus for many of the women, their treatment also would have been substantially delayed. The program's success is due in large part to a large network of professionals, coalitions, and national organizations dedicated to the early detection and treatment of breast and cervical cancer. And you'll hear from some of them today. But they include more than 7,000 individuals who are members of this national network that work with the state health departments in support of this program. If we could, I'd like to ask you to turn your attention to the maps on mammography use. As Rick described the declines in mortality, I want to show one of the predecessors to that decline, and that is the rapid change in mammography utilization. Here, seeing in the 90s, the darker states in 99 are those where over 80% of women say that they have had a mammogram in the last 2 years. And see where we were at the beginning of the 90s, where most states were below 60% of women having that report. So there's been a substantial increase in the number of women getting mammography recently. And we're especially pleased that, in fact, the racial and ethnic disparities that existed early in the 90s have now been reduced substantially. What's our vision for the future of this? Quite simply, we want no woman to die because she lacked the knowledge, the access, or the finances for mammography screening or whatever test turns out to be more effective in the future. But we have far to go. We currently screen about 12 to 15% of the target population of 3.6 million eligible women, that is women with no health insurance, ages 40 to 64, who are in need of mammography annually. Identifying and educating and motivating these women who rarely or never have been screened because of cost and geographic access is challenging and labor-intensive, and often in some communities becomes a door-to-door, one-on-one campaign. We know that mammography is not perfect. It misses some cancers, and it finds lumps that are benign but cause women to undergo further tests and needless anxiety. When research determines other methods to be more effective or accurate, we are prepared to move quickly to help women receive the benefits of the new proven screening or diagnostic technologies. I want to tell you one story as an example of what's happening in states around the country. A woman named Beth's husband lost his job after 28 years. Before he lost his job, it provided their health insurance, and she received a mammogram every year. This time she waited 5 years before she got another mammogram. She might never have had another one had she not found out about Vermont's Ladies First program, the screening program there. She went in for her free mammogram, and it turned out to be none too soon. It showed a lesion that was cancer. The good news is that it was caught early and treated successfully. Without that Ladies First program and the help to get treatment, though, she would also not have been able to afford treatment. As such, though, it got her treatment and was able to reduce that financial burden for her and her husband. She credits it with saving her life. There are many stories like this out there, and while we like to hear of them, we are also concerned about the ones who we don't hear about who didn't get screening because they didn't know about it. And we hope we can reach more of these women and catch their cancer early. And when research from NIH or elsewhere provides us with something even better than mammography, we'll use the CDC-supported programs and community networks to get that science to women as quickly as possible. Thank you.
Let me ask you now about the mammography. We had a big controversy not too long ago as to whether there should be mammograms for women between 40 and 50, and this subcommittee took a very forceful position that those mammograms ought to continue, and we were accused of being political. I had a little hard time understanding that accusation. I do understand it sometimes, but had a little trouble there, and thought that if priorities were to be set, they ought to be set by the Congress as to where we wanted to spend the money. Dr. Marks, what's your view of the importance of mammograms for women between 40 and 50?
You know what the science has said, the consensus conference that came out of NIH. We believe that the data is becoming increasingly strong that mammography at those ages finds cancer early, that it can save lives. And in our program, we support the states screening women at those ages. That was not the case at the beginning of the decade when their recommendations were for women 50 and older, but it is the case now, and we're seeing those screening rates go up.
And one final question. On the issue of racial and ethnic differences, you say they are lesser now, but how much differences are there on racial and ethnic lines?
There still remain substantial differences in mortality rates by race. What we're seeing, though, is that the screening rates have narrowed substantially, and they appear to have been eliminated for African Americans and for Asian Americans.
And I thank you, Mr. Chairman, for calling this hearing and leadership on this issue that means so much to all of us, and to some of us perhaps more poignantly than others. As many of you know, both of my sisters, my only two sisters, both died of breast cancer at quite an early age. I often think that if they had had access to better screening and better care and earlier interventions, they would have lived much longer and still be alive today. So I've often thought that we had to declare a war on breast cancer. We've come a long way. About a decade ago, we added mammography screening as a Medicare benefit. Next, we turn to John Seffrin. Dr. Seffrin is the Chief Executive Officer of the American Cancer Society.
Cancer is the second leading cause of cancer death and the most frequently diagnosed. According to the American Cancer Society's database, we estimate that 192,000 new cases will be diagnosed this year, and over 40,000 women, our mothers, wives, sisters, daughters, and loved ones, will die of breast cancer. Many of them, most of them, needlessly. Regrettably, many of these deaths and cases will occur disproportionately among women from predominantly low-income and medically underserved communities. For example, my friend Dr. LaSalle Lafall referred to, the death rates among African-American women are 28% higher than among white women. We know that one of the contributing factors to this disparity is lower utilization of screening tests such as mammography. We have many challenges in beating this disease, but in cases in which we have the tools available that can help us detect this disease early, when it is most treatable, we must ensure that these tests are available to all who need them. Now, despite these grave statistics, it's becoming increasingly clear that breast cancer is not the automatic death sentence it once was. Indeed, we were looking at our data, and we have had great success in treating the disease when detected early, when it is localized and is not spread. According to the American Cancer Society's data, in the 1940s, the 5-year survival rate for localized breast cancer was about 72%. Through the development and the use of improved early detection and better treatment methods, the 5-year survival rate for localized breast cancer has increased to 97% today. Now, we've come a long way, but of course there is much that still needs to be done. For example, while we know that early detection is currently the key to survival, we also know that the majority of Americans are not getting appropriate screening.
Getting access for minority women is a real concern of mine. We know that they are 3 times more likely to die from breast cancer, and certainly there are cultural language barriers that prevent them from somehow from being diagnosed early, whether they're Asian or Native American or African American. Are we doing more to find out how we can reach out to minority women and better those numbers about the survival rates?
I would like to respond to that, if I may. And the answer to that is yes, we are doing more, but we're still not doing enough. Susan Komen Foundation, the American Cancer Society, particular Breast Cancer Coalition, all have programs related to outreach for those population groups that really don't take advantage of the opportunities that are